In terms of public policy, most likely our tools for addressing these questions are going to be on the payer side of things. We might think that the FDA would start both demanding and using value information, but that strikes me as a long political battle to get to that point. But payers, including potentially public payers, may be in a position to work on this problem through a variety of means. Senator Clinton, Secretary Clinton, I'm not sure what we call her now, Candidate Clinton, mentioned co-payments. And so, the proposal there was intended to protect patients from out-of-pocket cost burden, but that unfortunately would have the unintended effect of shielding these very high prices, again, from the decision makers. For the same reason, Medicare prohibits the use of copay coupons for Medicare beneficiaries, because they essentially make those products free to Medicare beneficiaries, and therefore there is no discipline regarding cost. So there's a bit of a trade-off there. Some other strategies that payers might use would include reference pricing, where payers pay for the high-value product in a grouping and require that patients pay the difference if they want another product that is no better and higher cost. Again, there's a bit of a trade-off in putting the onus on patients. Dr. Schnipper's remarks also raised the potential of educating both patients and their doctors about the out-of-pocket cost and value differentials across these treatments. And there may be an opportunity for shared decision-making that would really work at the point of care to encourage value to become part of the equation. None of these solutions is complete in and of itself, and none of them are without trade-offs, but some combination of changing the way we pay for drugs on the insurance side and some of the conversation between doctors and patients most likely will move us in the right direction.
So from a policy point of view then, what we like to call her presidential nominee, Hillary Clinton, when we talk about this capping these out-of-pocket costs, from a policy point of view, that you seem to be saying that is not necessarily a good idea. Does it work on some level for consumers?
It seems like pain relief to me, where the patient is bleeding and now you've numbed it, but they're still bleeding and you haven't gotten to the root of the problem.
So some of the other suggestions that she made had to do with negotiating with Medicare or trying to extend some of the Medicaid rebates. Medicaid has the well, other than the VA, as you mentioned before, I think, has sort of the lowest prices in the country with a 23% discount. Do you think that would work, negotiating with Medicare? Have we gotten to the point where sort of across the political spectrum that is a desirable outcome? I wonder who might want to. Aaron, maybe?
Well, yeah, I think so. I think, first of all, that the part of the Medicare Part D plan that prevented Medicare from negotiating was a distinctly political choice made over a decade ago, and does not make a lot of sense given the fact that Medicare either sets or negotiates literally every other medical expense, doctor's visits, radiology, hospital beds, everything it pays for, it either sets or negotiates the price for, except for prescription drugs. So I think that changing the law in that way would help a little bit. I think that another thing that will help with that negotiating and decision making is if there is the information in order to properly negotiate. So another thing that we lack, even if we gave Medicare the authority to negotiate, is the ability to say, well, drug A is better than drug B and drug A is, worse than drug C, and to be able to do those kinds of studies in order to provide Medicare with the tools it needs to negotiate properly. So that I think is another part of the puzzle as well.
So maybe we should just talk a little bit more about those cost effectiveness studies. I don't know who would want to jump in here first. I'd like to hear more about ICER.
Sure.
And I'd like to hear more about ESCO's tool.
I teed it up for you. You did. I see it right there.
Yeah.
Just take it straight. So part of the landscape, as we've discussed, is that we don't have a federal agency that does cost effectiveness in some way to provide Medicare with the answer, which is if you're going to go negotiate, what's the price that you should try to negotiate to? How do we decide that? And I think part of the fear of giving Medicare negotiating power is that it would just it would drive prices down too low perhaps, and it wouldn't meet the dynamic efficiency goals of the future. It would have too short-term a perspective. So again, virtually every other industrialized country has some federal institute or agency that tries to take this on. Since we don't in the United States, my independent institute, ICER, has been producing reports, and we just received new nonprofit foundation funding to basically ramp up so that within about a year we'll be able to produce a report for virtually every single new FDA drug at the time that it's approved by the FDA, where we'll be able to show in an independent analysis what is its comparative clinical effectiveness, how much better does it really help patients, both in the short term and in the long term. And then we're going to look, yes, at costs, both the short-term affordability issues, but long-term, because we want to make sure that we capture the good long-term value from drugs like Sovaldi. Again, I wouldn't necessarily argue that they got the price right even so, but I do think that we need a way to look at that. And our group is going to be providing these reports to try to trigger a different dialogue about pricing.